Good afternoon. On behalf of the Executive Director, staff, and Board of Northern Vermont AHEC, I welcome you to the launch of our new educational series, Quality Care is Equitable Care, the Case for Culturally and Linguistically Responsive Care. I'm Katina Cummings, Health Workforce Program Manager, and I will be moderating today's event. With the convergence of recent racial and ethnic violence in our country, a once-in-a-lifetime pandemic which is disproportionately killing Black people and other people of color, and growing health and other disparities between white people and minority populations, the time for engaging with colleagues on difficult but resolvable questions is now, and most of you are already doing it. We invite you to explore, reflect, and self-critique your role in the healthcare system and how the needs of all patients, especially Black and Brown people that live in our state, can be better and more justly served. In this series, we begin by asking, why does achieving health equity matter in a state with predominantly white and rural residents and practitioners? How does discrimination, even unintentional in American healthcare, affect health inequities and health disparities experienced by minority and underserved populations? This series will focus on why quality healthcare must be equitable care, how ignoring racial and ethnic health disparities is costly for underserved patients, providers, and society at large, and how culturally and linguistically responsive practices and organizations are necessary components to achieve a more equitable healthcare system. We will candidly address these and related questions and offer interventions and strategies that reduce the impacts of discrimination and biased care on our most vulnerable people. We hope this series will challenge, support, and inspire you on a professional and personal path to deepen your understanding of the roles of race and culture in assuring just health care for all patients. In today's session, we explore the meaning of health equity as the primary lens for assuring quality care for all, with special focus on recognizing disparities in health by race and ethnicity in rural areas as well. In session 2, which has been scheduled for January 28th of next year, David Hunt, one of today's featured speakers, will present the business, medical, and legal cases for health equity in patient care and the implications for changing demographics for the workforce, recruitment, hiring, retention, workforce incivility, and so forth, as well as for patients. Check the chat for a detailed flyer on session 2. For more information on sessions 3 to 5, which include racism and unconscious bias in American healthcare, please visit our website at www.nvtahec.org. Briefly, you will see today's agenda posted here. I will give an introductory session on achieving health equity. Why does it matter in Vermont, followed by Mr. Hunt's presentation on 3 demographic megatrends in a globally mobile world. We will have a 10-minute break following his presentation, followed by Dr. Carrie Henning-Smith on health disparities by race and ethnicity in rural America. Then we will host a brief 10-minute reflection and response exercise for your participation. And finally, an introduction to the path to culturally and responsive practices. We will conclude at 2:25, or excuse me, at 2:30. This program would not be possible without the contributions of our planning committee members listed in front of you. We thank them all. And we are extremely grateful for the support of this program's endorsers who are committed to achieving health equity and have helped get out the word far and wide about today's event, as well as other planning details. Thank you to all of you. All participants will receive a certificate of completion after the event by email. If you are interested in receiving continuing education contact hours or credits, please complete the evaluation form at the end of the program. A registration form will be sent to you separately by email. Continuing education, professional education is being offered to physicians, PAs, nurse practitioners, nurses, social workers, allied mental health professionals, and psychologists, and will be offered for the other 4 sessions as well. A few quick announcements. This webinar is being recorded. All participants will remain muted throughout the webinar. Your controls are at the bottom of your screen, and please use the chat function for comments and questions that are related to the presentations. You may open your chat window now if you haven't. Please use the Q&A button for technical questions only. The presenters will take questions as time allows, and links to the continuing education forms will be emailed to you after the program. Please complete the evaluation again at the conclusion of this webinar. So I will introduce Achieving Health Equity in Vermont, Why It Matters. So it's important for us to be clear about the concepts of health equity and health disparities if we want to clarify the concept into practice, which we do want to do, and all of us are doing it in some shape or form. Also, any ambiguity or confusion could lead to unintended consequences, such as directing limited resources away from intended purposes for the most disadvantaged socioeconomic groups. So most of you know that health equity has long been an ideal, with roots in social medicine back to the mid-19th century, when social critics and visionary public health leaders recognized that social and class inequalities led to inequities in health. Principles from the fields of human rights and ethics are the foundational bedrock of health equity, from the Constitution of the World Health Organization and the Universal Declaration of Human Rights of the United Nations, that put forth that everyone is entitled to enjoy the highest or adequate standards of health without regard of their race, religion, political belief, language, or even social origin. Let's examine quickly 2 mainstream and highly regarded definitions with different underlying concepts. The Robert Wood Johnson Foundation defines health equity as expanding opportunities for everyone to live the healthiest life possible, no matter who we are, where we live, or how much money we make. Certainly, this is aspirational. It's one based on equality of circumstances. The World Health Organization definition begins a bit in the reverse and sounds to me at least more like a destination. The absence of unfair and avoidable or remedial differences, please note those adjectives, in health among population groups that are defined socially, economically, demographically, or geographically. So, what are health inequities? Next slide, please. They are differences in healthcare that are avoidable, unfair, and unjust. And as we just heard from the World Health Organization, they are actionable. They can be remedied through research, changes in policies, systems, and provider practices. Next slide, please. So health equity, what does it mean? Well, we've touched on it, that everyone has fair and just opportunity for good health. But Paula Braverman expands that definition of opportunities to just and fair opportunities, by the way. And there's a second critical part to the definition, the ethical and human rights principle or value that motivates us to eliminate health disparities. The first time we have heard the term health disparities. We'll return to that idea in a couple of minutes. Next slide, please. So when do we know that health equity is achieved? Well, according to the National Health Law Program's Equity Stance of 2020, it is when a person's characteristics and circumstances, both, including race, ethnicity, gender identity, sexual orientation, language proficiency, do not predict their health outcomes. This is one of the clearest and strongest statements I have read to date about the achievement of health equity. These characteristics and circumstances should not limit people's experience in the world, so that everyone, they say further, can achieve an optimal state of well-being, not just health, and where everyone has a fundamental right to their highest attainable standard of health. I just want to comment here, there is no single approach to achieving health equity. Solutions lie within the health system and outside the health system, as we know. Next slide, please. Many of you are probably familiar with the Healthy People 2020 definition of when health equity is achieved. That definition elevates health equity to a societal responsibility, focused in ongoing societal efforts to address three elements: avoidable inequalities, historical and contemporary injustices, and here we go again, the elimination of health and healthcare disparities. So on a practical level, addressing historical and social disadvantage is key to advancing health equities. Number two, Braverman says the highest possible, on a practical level, let's think about what that means. It means that the highest possible standard of health can be reflected in the level of health among the most economically and socially privileged group in a society. I think we would all agree that the President of the United States is among the most socially privileged in society. You might recall that President Trump received celebrity treatment for COVID-19 with Regeneron's monoclonal antibody cocktail that was not available to most Americans except by a lottery system. Next slide, please. So everyone is valued equally. This is a message that comes from the USCRI, which is our refugee resettlement program in Vermont. And I kept this visual for over 5 years because I think it expresses the kernel of health equity. Next slide, please. So let's go back to health disparities. The term health disparity was coined in the US around 1990, and it's important that it was not meant to refer to all possible health differences among all possible groups of people. It is, as the definition shows, observable differences in health outcomes among and between groups of people. It was intended to denote a specific kind of difference, namely worse health among socially disadvantaged people, and in particular, members of disadvantaged racial and ethnic groups, and economically disadvantaged people within any racial or ethnic group. The second part of her definition of health disparities is important. Not all health differences are health disparities. And examples include worse health among elderly compared with young adults, or a higher rate of a particular disease among billionaires than non-billionaires. So to conclude, some differences in healthcare and health outcomes are inevitable and are neither the evidence for nor the result of injustice. Next slide, please. So health disparities has been called a phenomenon by Dana Bowen Matthew in her book, Just Medicine, and tragic proof that racial and ethnic injustice is alive and well. So that term connotes meaning to people in practice today. A significant cause, and to quote her further, of these health disparities is unconscious racial and ethnic bias that infects our delivery system. Implicit racial and ethnic biases in healthcare are harmful. They are avoidable, as we discussed earlier, and unjust. Health inequality due to unconscious discrimination is a structural malady in need of a systemic cure. And as we proceed in our series, this conversation will be highlighted. Next slide, please. So we can conclude that health disparities are inequitable. Why? Because they further disadvantage an already disadvantaged group. And that health is necessary to overcome limited opportunities and artificial barriers. The key here is to remove obstacles to health, such as poverty, discrimination, and deep power imbalances, and the consequences on vulnerable populations. Next slide, please. Most of us are familiar with and can name the social determinants of health, also known as drivers of health. And these have garnered remarkable long-standing attention, especially in the context of population health and value-based contracting. They are the conditions in which people are born, grow, live, learn, work, play, worship, and age. And there are 5 domains. You can see them on the screen. These are the conditions in the environments where people live and work and so forth. And they affect a wide range of health and functioning, as well as quality of life outcomes and risks. So it's important to remember that resources such as housing and quality schooling, well-paying jobs, are differentially allocated among groups, even when those groups may be following the rules of the game that are set before them. So resources needed to be healthy are not only medical care, but health promoting living and working conditions. The second key point, which is not on this slide, but is critical for our work, is that bias, racism, and discrimination are embedded in every single domain, historically and contemporarily. We won't have time to go through all of them, but we do know that racial segregation, for example, has greatly impacted fair housing for millions of Americans of color. When discrimination is experienced by an individual, it becomes a major life stressor, a stressful experience. And research shows that experiences of discrimination and racial violence are detrimental to the health of vulnerable people. So race and ethnicity then can be considered determinants and should be considered determinants of health, which create health disparities. Next slide, please. So social disadvantage is important to talk about for a moment. It's a broader concept. It includes economic disadvantage, such as low income, lack of wealth, inability to purchase goods, but it also refers more generally to someone's relative position in the social pecking order, in which individuals or groups can be stratified by their economic resources. That's the first bullet, money, power, and resources that are part of social determinants of health. But also their social pecking order is determined by their race, ethnicity, religion, gender, disability, and so forth. Social disadvantage does include economic disadvantage, and there's a massive body of evidence that links economic and social disadvantage with avoidable illness, disability, suffering, and premature death. Again, race and ethnicity can be considered determinants of health and create health disparities. Next slide, please. So the link between health equity and health disparities, I believe, is as following. Health equity is social justice in health in a nutshell. It's social justice in healthcare. And what that means is no one is denied the possibility to be healthy for belonging to a group that has historically been economically and socially disadvantaged or socially disadvantaged. Braverman, again, from the University of California, Southern California, notes that health disparities are the metric that we use to measure progress toward achieving health equity. That's the link. It's a reduction in or elimination of health disparities in absolute and relative terms. And it's evidence, disparities are evidence that we are moving toward greater health equity. Next slide, please. Most of us have seen this graph or something close to it. And it's important too to discuss or understand that equality is not the same as equity. Equality, on the left, you see three individuals who are looking to watch a game. Equality aims to ensure everyone gets the same things, to enjoy full healthy lives. So if we treat everyone equally, we would give everybody the same box. You can see that on the left to stand on. So only the tallest person in that picture can watch the game. Like equity, equality promotes fairness and justice, but it can only work if everyone starts from the same place and needs the same thing. Now, in the middle, equity, giving people what they need to reach their best health, is the core of equity. And if we treat people equitably, we would give them as many boxes as they needed, right, to see over the fence and enjoy the game. As you see the smaller person or child on the right, who needs a larger box than that one in the middle, and the one on the left needs none. So equity can be equated with fairness based on individual need. Justice is what I love about this description. No supports are needed because the systemic barrier has been removed. Under justice, it aims to remove those unjust and unnecessary differences, requiring us to consider changing our practices, our resource allocations, our social and health institutions, and our policies. In other words, systemic and structural change. Next slide, please. So quality care is equitable care, and that is the theme of our entire series. And why did we pick that theme? Equitable care is more than equal access to services. So distributional justice, which I just described, is the argument that society must fairly allocate healthcare in order to equip all members of society to participate in life's normal activities. But distributional fairness alone does not and will not eliminate racial and ethnic health disparities. A just healthcare system will require rooting out biases and discrimination that affects patients differentially. That is substantive justice. So equitable implies receiving equal quality of services. And without that same quality of care, there is injustice. Next slide, please. So let's go further. We're not the only ones that thought about this, of course. The Institute of Medicine has been working on this question for years and has recognized that quality care must be equitable care. The IOM developed a framework for quality assessment, 6 aims for the healthcare system. They're also called domains of quality. Existing measures address, and you can see them, I'm not going to go into detail on all of them, safety, effective care, timely care. These measures address some domains more extensively than others. The vast majority of measures in each domain address effectiveness and safety. A smaller number examine patient-centeredness. Very few assess the equity of care. So next slide, please. How does the Institute of Medicine define equitable care? It's circled there. Providing healthcare of equal quality to those, equal quality, there's the quality question, to those who may differ in personal characteristics other than their clinical condition or preferences for care. It is care that does not vary in quality because of those personal characteristics. So also, equitable care has probably been given less attention in the quality world because it's more difficult to talk about, and we've had more trouble as a country measuring it. Next slide, please. Let's hear from Dr. Kedar Mate, who is CEO of the Institute for Healthcare Improvement, on the role of equity in quality healthcare.
Very simply put, how can we say that we have a high quality system that leaves out a third of the population, or half of the population, whatever it is? How can we say that we have a good system even when half don't get to participate? We've argued historically that we should focus on the better performers and call attention to those better performers in any system, because that would create a strategy of attraction and help move the whole curve along. But what if the people that are at the bottom of that system are systematically prevented from ever achieving anything in that body of work? I think that if that's the circumstance, you have to re-examine the premise. You have to change your way of thinking around how we achieve better quality. We can improve median performance of a system. We proved this to ourselves at IHI, and others have done the same. We can improve the median performance of a system and yet increase disparity within the same system, meaning we can make the overall result better and make it worse for one segment of the population rather than making it better for all. And this is, I believe, often the case. Consider the deployment of any new technology. When we have a new diagnostic, a new therapeutic, a new device, a technology of any kind, who does it immediately go to benefit first? Not everyone, typically. It goes to benefit those with the most power, those with the most prestige, those who are in the privileged classes, broadly speaking. And only later, and with discipline, attention, and energy, might it flow down to those that desperately need it, who don't have the same franchise. And so you cannot have quality in the aggregate across a whole system without equity in our work. You can't have it in anything, not just in healthcare. You can't have quality of anything without equity. And that goes true as well for healthcare.
So in spite of focused attention from lawmakers and policymakers, healthcare providers, scholars, and others, research shows a picture of how far we have not come. Granted, there have been improvements in the overall quality of medical care in the US, and they have narrowed persistent gaps in some key disparities indicators, but we have been making little progress finding effective solutions to the structural nature of these injustices. And these are three reasons why a health equity lens matters today. Because those inequities are persistent and widening, because we need to improve patient care outcomes, particularly with a focus in primary care, and we need to reduce costs. Next slide, please. So the interventions for health equity can occur on both and should occur on both the individual practitioner level and the organizational level. We are focusing on three strategies. In the individual level, we need to use educational opportunities and integration strategies to enhance staff knowledge, confidence, and practices. On the organizational level, we need to use approaches and practices that foster shifts in organizational structures, financing, practices, and other policies. So the three strategies focus on culturally safe and responsive care, 2, trauma-informed care, and 3, How do we better assess disparities between conventional care approaches for underserved populations and people's needs? Next slide, please. I think it's important too that a health equity lens, or seeing differently, must address structural inequities. And those structural inequities in the areas of social, economic, political, and environmental arenas can result in poor health outcomes across generations. They can have, those inequities can have a greater influence on health outcomes than individual choices or a person's ability to access healthcare. Critical point for all of us. And not all communities are impacted in the same way, especially generationally. Next slide, please. So what are examples of persistent and widening inequities? Black, Indigenous, and patients of color consistently receive fewer, and take a look at that list. This is true today. And even after controlling for differences in insurance status, income, education, geography, racial and ethnic differences in health treatment and outcomes persist, resulting in inferior treatment. Next slide, please. This one is very important because preferred language is also a category that is an element of disparate treatment. This is a very newly released, I think within the last month, ARC-supported study. About pediatric patients. Hospitalized children whose parents are not comfortable speaking English are twice as likely to be harmed than those whose parents express comfort speaking English after controlling for other factors. The authors called for targeted strategies to improve communication and safety for this group of children. Next slide, please. So examples of persistent and widening inequities would take an entire webinar to do. But it's important to note that Black, Indigenous, and patients of color receive less treatment. They have more complications, but yet they are sicker and they are more likely to die than white patients from a wide range of disease and illnesses. And we're going to be talking later that that is true not only in urban areas, but in rural areas as well. Next slide, please. Some of you have probably seen and know that white Vermonters represent the majority of COVID cases, and African-American Vermonters have the highest rate of COVID. According to Department of Health Weekly Summary Report, these figures are from March 5th to September 16th of 2020. In an article yesterday, I mean, these are huge disparities here. In an article yesterday in the Vermont Digger, we are seeing that the disparities in COVID cases are continuing. Next slide, please. Also, mental health inequities are part of the story. Minorities in the US are less likely to receive mental health treatment when indicated than are white Americans. And at the same time, mental health providers are less likely than general medical practitioners to be Hispanic, Black, Asian, or Native American. Next slide, please. So quality and access measures on health disparities show us that the racial quality gap remains relatively constant since 2000. Some measures are improving, such as acute hospital care, but you can see some of those that are worsening. Disparities in most of these measures have not narrowed since 2000, when the data was first analyzed and reported. In 2018, Black and Indigenous Americans received worse health care than white Americans on 40% of the quality measures analyzed, 40%. And there's more analysis to do from that 2018 ARC report, and you can look into it on your own, and we can share with you that link. Next slide, please. So the cost of inequities in human lives and medical costs have been quantified through research. By one estimate, this is staggering, and this was from 2005, over 83,000 minority patients die annually due to healthcare disparities. And there's another measure, over 30% of direct medical costs of African Americans, Hispanics, and Asian Americans are considered excess costs, nearly $230 billion between 2003 and 2006, as reported by the Joint Center for Political and Economic Studies in 2011. So, as again, I'm quoting Dana Bowen Matthew in her book, Just Medicine, the conclusion is inferior and racially based biased healthcare kills people of color, and it costs them lots of money while they're doing so. It's cryptic, but it happens to be true. Next slide, please. So the good news is that there is momentum on the path to achieve health equity across the country. But according to Dr. Joseph Betancourt in Massachusetts with the Health Disparities Center, if these efforts are to be truly transformational, a culture of equity in every effort must take root. This challenges all of us, providers, leaders in healthcare, even administrative people in the health and social services fields, to deliberately consider the effects of our work on all populations, not just a select few, and whether our work, this is the question, lessens or widens disparities in healthcare. He believes, Dr. Betancourt, that the process must become a mandatory function in all efforts. Next slide, please. So in conclusion, I'd like to add that all people living in Vermont, not just those that are socially and economically disadvantaged, benefit when we reduce and eliminate health disparities. There is a universal impact to health equity, and that all of us must be part of the solutions. Thank you so much. And with that, I am happy to introduce our first speaker, our first featured speaker of the day, David Hunt. Hello, David.
Hi, Katina.
Great to see you.
Thank you.
David Hunt is, I'm going to give a brief introduction, David, and you can add anything you would like to it. David is the Senior Director of Health Equity at BCT Partners. It's a national management consulting and training firm specializing in diversity, equity, and inclusion issues. He wears many hats. He's a former employment law and civil rights attorney and is nationally known for his expertise in racial and ethnic disparities in healthcare, the law of language access, global medicine, and the new science of unconscious bias. He, together with leading physicians from Harvard and University of Minnesota medical schools, he has created the nation's first CME accredited e-learning programs on cultural competence and global medicine for doctors and nurses, with over 180,000 providers trained. And he's collaborated more recently with leading physicians to create a provider cross-cultural medical assessment. I met David when I worked in Kentucky in refugee healthcare, and it is an ongoing collaboration with David as I moved to Vermont about 1.5 years ago. So thank you, David, for joining us. He is going to address the 3 demographic megatrends in a globally mobile world.
Thanks, Katina, for that kind introduction. It's great to be with all of you today. Again, my name is David Hunt. I'm the Senior Director for Health Equity at BCT Partners. And I just have to say, I mean, now that I've been outed as an attorney, I don't know how many of you saw the classic film Jurassic Park, but when I saw that film, the only time in the whole movie that the audience cheered was when the dinosaur ate the lawyer. So I understand how people feel about lawyers. And a number of years ago, my youngest daughter, Sarah, asked me to go to school with her. And it was one of those take your parents to school days, right? And so the night before this penultimate event, I'm sitting up with my daughter, Sarah, and she looks at me, she says, well, Dad, I know you do a lot of, I know you do a lot of public speaking and this, but what do you do all day? And I said, well, Sarah, I said, as a lawyer, I talk to a lot of groups, but I really help my clients solve their problems. And so the penultimate, event comes up, and Sarah stands up in front of the class and says, this is my father, David Hunt. He's a lawyer. and he makes problems for people. And I try very hard not to make problems for people, but I would tell you that just as there are doctors who practice preventive medicine, in a very real sense, I'm a lawyer that's practicing preventive law. And you'll see what I mean as we get further into my presentation. I did practice employment law and civil rights law for a number of years. I often tell folks that I left the formal practice of law to pursue justice. And candidly, when we talk about eliminating racial and ethnic disparities in American healthcare, that's exactly what we're talking about. We're talking about bringing about a more just and fair, equitable world. I'm going to skip some of these opening slides and jump right into today's agenda. Briefly, during my time together with you today, I want to talk about 3 demographic megatrends, their implications for the healthcare workplace, and finally, their implications for patient care. The 3 demographic megatrends that I want to start with are these: issues of race, issues of immigration, and thirdly, new cultural influences that stem largely from that process of immigration, right? So if you want to do something really interesting in the next few minutes, take out a pen or pencil and draw 3 circles on a piece of paper. Those 3 circles represents the world's population at 3 distinct points in time: 1900, 1950, and the year 2025. Here's my question to all of you. If you were going to take your best guess as to what the percentage of the world's population was between whites and people of color in 1900, 1950, and 2025 in percentage terms, what would those percentages have looked like? And particularly, most particularly, what would they look like in 2025? All right, so I'll give you just a minute to think about that. So again, we're not talking about the United States here. We're really talking about the issue of race from a global perspective. Population, world's population, percentage white and people of color, 3 distinct points in time: 1900, 1950, 2025. Okay, time's up. Where were we in 1900? Well, in 1900, about 70% of the world's population was of color. 30% was white. That may come as a shock to some of you. It certainly was to me the first time that I heard that statistic. Fast forward 50 years, certainly not a long period of time in terms of global history. Here's how those percentages would have changed. By 1950, 76% of the world's population was of color, 24% was white. Where are we likely to be in 2025, which is, of course, less than 4 years from now? Here's what the world health population is projecting: 91% of color, 9% white. Now, recently I was on a college campus and I showed these statistics, and then we took a break and a professor came up to me on the break and said, "Why are you trying to scare our students?" And I said, "I'm not trying to scare your students. I'm trying to enlighten your students about the world that they're going to be inheriting, because I think that these trends are incredibly pregnant with implications for all of us." Okay, so we've talked about this issue of race from a global perspective. Now let's come home. Between now, 2020, and the year 2050 in the United States now, almost 90% of future US population growth will be coming from communities of color, from Asian Americans, African Americans, Hispanic, Latino Americans. 2 years ago, for the very first time, we had more children of color born in the United States than white children. Already today, not tomorrow, today, already today, people of color constitute a majority in 48 of the nation's 100 largest cities. We just got through with a major presidential election. If you like to follow politics, and I do, it's not lost on me and probably not lost on you either, that we already have 5 states that have minority majorities. And they include such political bellwether states as California and Texas and Florida. In addition to that, we've got 5 other states that are right on the cusp of flipping over and becoming minority majority. And among those states include the major state of New York. Put all those trends together, that's megatrend number 1, race. The second trend is immigration. One of the people that I follow and follow closely is Thomas Friedman. the author of The World is Flat. He's a frequent commentator in the New York Times and on CNN. One of the things that Friedman reminds us of is that if we look around our world today, 1 out of every 10 global citizens is a migrant. Now think about that with me. That's an astounding trend. Never before in all of human history have so many people left their countries of origin for economic opportunity around the globe. That's clearly what's going on today. Immigration to the United States has tripled in the last 30 years, and we have benefited tremendously from that influx of talent. 28% of our doctors today, 23% of our nurses today are foreign born. Without that infusion of medical talent, we wouldn't have the talent that we need to meet the current crisis. Here's what else is important. Oftentimes people get lost in these numbers, right? But it's important to remember the cultural patterns, because that's what's truly significant about this trend. And significantly, the vast majority of our immigrants today no longer come from Western European nations with whom we have the most in common historically and perhaps culturally. Increasingly, our immigrants are coming from around the world, from Eastern Europe, from India, China, Southeast Asia, Vietnam, the continent of Africa, Mexico, and South and Central America. The result of all of that is simply this, that the ability to navigate difference is becoming the signature professional skill of the 21st century. Let's briefly put some meat on those bones, okay? Guess what our best business schools, our best MBA programs are teaching today? They're teaching diversity. Do they call it that? No. They call it global business skills. But mind you, what they're teaching is diversity. They're teaching cross-cultural sales, cross-cultural marketing, cross-cultural communication, cross-cultural negotiation, cross-cultural conflict resolution. Every medical school in the United States today is teaching cross-cultural medicine because of the implications of these trends. And 6 states have changed their physician licensing laws to require physicians, as a condition of licensure, additional training in cross-cultural and global medicine. Finally, in my own field of law, in my home state of Minnesota, every lawyer, every judge, as a condition of licensure, has to take ongoing coursework in the elimination of bias in our legal system. Minnesota and California are already 2 states that have that requirement. The American Bar Association is now requiring every state to follow suit. So the ability to navigate difference is becoming the signature professional skill of the 21st century, no matter what your field of endeavor, right? Third and last megatrend is this: new cultural influences, which stem largely from that process of immigration. 2 big cultural influences we want to talk about. First one is religion. Islam is now the fastest growing religion in the United States, carrying with it important implications for patient care and also important implications for the healthcare workplace. Muslims pray 5 times a day. Are hospitals required to honor that religious commitment? In fact, they are. Is it easy to do? Yes. Muslims pray once in the morning before they come to work, once at morning break, once at lunch, once at afternoon break, and again when they go home. Not hard to accommodate. The second big cultural influence is this: language. And Katina alluded this, but around our country today, 21.5% of Americans over the age of 5 speak a language other than English at home. Now, that doesn't mean they don't speak English, but it does mean that at home, in the privacy of their own homes or cultural communities, they may speak languages other than English. In some states, our biggest states, over 40% of the population speaks languages other than English. Around the United States, over 300 languages are spoken today, making the United States even more linguistically diverse than Western Europe. So what are the implications of those megatrends for the healthcare workforce? I want to suggest that there are 6 major implications. There are implications for recruitment, hiring, and retention, for productivity, for diverse workforces, because diverse workforces have both pros and cons. We have to talk about both. We also have to talk about rising incivility and legal liability, because employment law is becoming diversity law. And finally, we have to talk about management, commitment, and expertise in managing a diverse workforce, which is another new professional skill. Let's start with recruitment, hiring, and retention. If we think just about the changing demographics of the American healthcare workforce, one of the things that jumps out at me is that 85% of our future workforce entrants will come from three groups: from women, from people of color, and recent immigrants. Of those three groups, immigrants are likely to compose the largest group, 60%, requiring then that managers and leaders have the ability to manage across cultures. Why is that difficult? Because the roles of managers and employees are different across cultures. They're not the same. Those roles, in other words, are culturally relative. Another reason why this is becoming a big issue is that 67% of new workforce entrants today consider diversity an important factor when they're deciding where to work. Young people in particular want to work for diverse employers, which is why, not surprisingly, 65% of senior executives said that the recruitment of diverse employees was their top priority, and they have programs in place to achieve precisely that goal. So this is an issue not only about recruitment and hiring, but also very much about retention, keeping the talent that you find. One of the reasons that that's problematic is that the number one reason why workers leave their jobs is their manager. So we're telling managers around the United States, if you can't manage a diverse workforce, fundamentally, you're not qualified to manage the workforce that is swiftly emerging around the United States today. As we look for top talent, many of you are already, I'm sure, smiling because you've seen this YouTube video about Susan Boyle. Susan Boyle went on a British talent show called Britain's Got Talent. She was from a Scottish fishing village. When she came on, the audience immediately began tisk-tisking. They couldn't believe that a woman like Susan Boyle would have the audacity to claim talent on this show. And the most amazing part of that YouTube video is the audience's reaction to her. Who does she think she is? She's not young, she's not pretty, she's not beautifully dressed. Who does she think she is? They were actively rooting against her. So then they asked Susan Boyle, what are you going to sing for us today, Susan? And she says, I'm going to sing I Dreamed a Dream from Les Miserables. And they cue the music, and Susan Boyle sings with the voice of an angel. And I think that reminds us of two critical points. First point, great talent often doesn't look and act like you. And secondly, can you spot great talent no matter how it's packaged? And that's particularly important because this is where our unconscious biases get in. It's almost like when we do that recruitment and hiring, it's almost like every one of us has an invisible mirror in our hands, and we open up that mirror and we look into it and we go, oh, well, now there's a qualified candidate. Now I know what one looks like. It looks just like me. And then we screen people in or out on that basis. Diversity, we're also learning, is very much a productivity issue. The best research suggests that the organizations, the employers that really get this, get an increase in productivity anywhere from 18 to 31%. What's the secret sauce behind that? We're learning that it's not so much employee engagement that matters, but rather employee inclusion and belonging that produces discretionary effort in our employees. Gallup has done some really interesting work on this, and they found that 75% of American workers are not fully engaged at work. That costs the American workforce and employers somewhere between $450 billion and $550 billion a year. So the question is, what causes workers to disengage? Well, certainly there are many answers to that question, but one of them, which is often overlooked, is what I call DRIs. And that's a term you should be familiar with because DRIs stands for diversity-related incidents of disrespect. Diversity-related incidents of disrespect. What percentage of workers experience these DRIs at work? According to the Brookings Institution, 71%. Notice how close that 71% figure is to that 75% of American workers who are less than fully engaged at work, right? So when it comes to diverse workforces, there are pros and cons. Diverse work teams have many advantages: superior problem-solving ability, better decision-making ability. They're more innovative, they're more creative, more likely to produce new product and process ideas which match the needs of an increasingly diverse marketplace. They also have better insights into culturally and linguistically diverse clients. So they have, in effect, a window on the world. But at the same time, diverse work teams also face several key challenges, and we have to be honest about these. Diverse teams take longer to gel. Decisions and consensus takes longer because there are more opinions around the table. There is more conflict. But it's not just that there is more conflict, it's also that there are different conflict styles. And that's really important to understand. In fact, in my work, one of the tools that I use is a tool called the Intercultural Conflict Style Inventory. It's much like the Myers-Briggs of cross-cultural conflict. You take the tool, you find out what your culturally influenced conflict style is and how your style compares to 4 other styles around the world. It brings out major differences in terms of the ways that the races deal with conflict, and also very substantial differences in the ways that people from different cultures deal with conflict. What's at the heart of that increased conflict in diverse workforces? And it has to be said, it's less trust, and trust is earned. And the ability to generate trust across cultures is, again, part of that professional skill of cultural competence, which I mentioned earlier. Growing incivility at work. 70% of Americans believe workplace incivility has reached crisis proportions, and it has. This is a trend that has been spotlighted by the Harvard Business Review. It's been increasing in the United States for the last 15 years. It substantially predates, by the way, the Trump administration. But the costs of growing incivility at work are substantial. Significant decreases in productivity, employee engagement, teamwork and safety at work, employee retention, and increased turnover. And also, from the standpoint of patient care, as one survey of more than 4,500 doctors, nurses, and other hospital personnel found, 71% of these providers tied abusive, condescending, or insulting personal conduct to medical errors. And 27% tied such behavior to patient deaths. Connected with workplace incivility is a major trend in terms of workplace bullying. 60 million US workers are affected by workplace bullying every year. Very substantially, it's protected groups who are bullied the most, particularly by gender and certainly by race. Workplace bullying is a particularly important phenomenon to note in healthcare, because while 60 million American workers experience bullying annually, healthcare leads the country. Healthcare ranks number 1 of any industry in the United States in terms of the episodes of workplace bullying. And nurses are now the number 1 target of that workplace bullying in the United States. It used to be teachers. Today, it is no longer. Today's nurses are the number 1 target of workplace bullying. Between 18 to 31% of nurses experience workplace bullying annually, according to the American Nursing Association. So one of the things that we do for our clients is we do diversity workforce assessments. For a major hospital client recently, we looked at 4 different types of disrespect. Disrespectful behavior generally, diversity-related incidents of disrespect, those DRIs that I mentioned earlier. We looked at workplace bullying, and we looked at outright discrimination using traditional EEO categories. As you can see from this chart, this is a major hospital system in the United States, major differences between white employees and employees of color in all 4 of those areas, with Black employees being particularly disrespected and discriminated against. Significantly, we also found similar differences when we broke out those same 4 categories of disrespect by male and female physicians and white physicians and physicians of color. with female physicians being substantially more likely than their male physicians to experience these kinds of disrespect, and physicians of color and foreign-born physicians far more likely to experience these incidents of disrespect than their white physician colleagues. From someone who's practiced both employment law and civil rights law, it's not lost on me and probably not lost on you either that employment law is becoming diversity law. The expansion of the hostile workforce theory of discrimination and harassment, now courts have expanded that to include not just sex-based or gender-based discrimination, but race-based, ethnicity-based, age-based, disability-based, national origin-based, think immigrants, religious discrimination and harassment, sexual orientation, gender identity, and so forth. So employment law is rapidly becoming diversity law. And we know that harassment and discrimination claims are expensive. If you think about the American court system, it has two branches, the civil side and the criminal side. Today, 1 out of every 3 civil cases is an employment law case. Now, the vast majority of those cases settle. 85, 90% of those cases settle. But if even one of those employment law cases goes to an employment law jury verdict, 1 out of every 5 employment law jury verdicts today is a $1 million case. So managing a diverse workforce means managing certainly the legal liability that can potentially attach to that workforce. And this is also very much becoming a management commitment issue. Again, for a recent hospital client, we performed a diversity workforce assessment. One of the questions in that assessment was, my organization would benefit from increased workforce diversity. Notice the operative word there is increased. My organization would benefit from increased workforce diversity. Well, as you can see from this table, 80% of the executives in that organization strongly agreed that their organization would benefit from increased workforce diversity. The directors were pretty much on board with the executives. But by the time you got to the managers, we saw a 10% difference in levels of agreement. And by the time you got to the supervisors, who are, after all, on the front lines of implementing these diversity initiatives, it was literally a 16% difference. So if this organization was committed to diversity, apparently somebody didn't get the memo. Equally interesting was when we asked the same question and broke out the results by clinicians and providers. 84% of physicians in this organization strongly agreed that their organization would benefit from increased workforce diversity. But only 62% or 18% less of RNs supported that proposition, and far fewer LPNs did. So if this organization was going to tackle or improve workforce diversity, clearly one of the stumbling blocks would be the nurses and LPNs. Let's turn now to the patient care implications. For me, when we think about those implications for patient care of those 3 demographic megatrends, the 3 key trends I want to highlight are these: issues of racial and ethnic disparities in patient outcomes, providing language access to limited English proficient patients and their families, which is both a medical quality and safety issue, as well as a legal and civil rights issue. And finally, the emerging issue of global medicine, which doesn't get nearly enough attention. But let me talk about each of these key issues in turn. Racial and ethnic disparities. We know the historical backdrop of prejudice and racial discrimination in healthcare in the United States, dating all the way back to colonial times, up through and extending through the Tuskegee syphilis experiments and many others. In 2002, the Institute of Medicine convened a nationwide panel to look at the extensiveness of racial and ethnic disparities across the United States. That panel was out for over a year. They looked at mountains of evidence. One of my colleagues, Dr. Joe Betancourt from Harvard, sat on that panel. And after looking at all of that evidence, their number one conclusion was simply this: that people of color receive lower quality healthcare than whites, even after we adjust, as Katina mentioned earlier, for insurance status, income, age, and severity of conditions. We can hold all of that constant, and yet people of color are receiving lower quality care than whites. Now think about the irony of that, because what that suggests is that our fastest growing patient populations are receiving the worst care in American hospitals, right? The Institute of Medicine found major disparities in many key diagnostic areas, whether it was heart disease or cancer or stroke, kidney dialysis, HIV and AIDS, asthma, diabetes, mental health, maternal and child health care. That was 2002. Where are we today? If we want to get a concise answer to that, the best place to turn is the Agency for Healthcare Research and Quality, AHRQ. If you're interested in these trends, go online to the AHRQ website. Every year, the AHRQ publishes a national racial and ethnic disparities report. There, you can look at your own state's disparities, and you can also look at trends in national disparities. As the table at the right demonstrates, however, disparities have not improved when we compare patients of color to white patients. The red demonstrates the numbers of conditions that have worsened for each one of these racial populations. The yellow or gold area suggests areas where they're the same, and the green area, the smallest area of all, shows the few areas where they've improved. And Katina mentioned that racial and ethnic disparities cost the US economy dearly every year, including $245 billion, with an estimated $35 billion in excess healthcare expenditures, $10 billion in illness-related lost productivity, and nearly $200 billion in premature deaths. The second big issue I want to talk about is language access for limited English proficient and deaf and hard of hearing patients. There's a strong business case, a strong medical quality and safety case, and a very strong legal and civil rights case for providing language access to limited English proficient and deaf and hard of hearing patients. The business case starts with this. Certainly the growing demographics. You'll remember 21% of the United States today does not speak English at home. The number one factor that limited English proficient patients and deaf and hard of hearing patients are looking for in the healthcare system is the ability to communicate and the ability to communicate effectively. We've worked with leading hospital systems to dramatically increase their share, their market share of LEP and deaf and hard of hearing patients by improving the quality of their language access services. Secondly, this is very much a quality and safety issue. Katina shared some of the recent outcome data with regard to pediatric patients in America's children's hospitals. But one of the things we have found, and this has been known for quite some time, in a study published by the Joint Commission, is that LEP patients are almost twice as likely as English-speaking patients to suffer permanent physical injury or even death when they do not receive qualified medical interpreters. They're also much more likely to be subject to medication errors, much more likely to be readmitted into our hospitals, which negatively impacts reimbursement rates to our hospitals for Medicare and Medicaid, and substantial overuse of the emergency room. Where are we today? In a nutshell, 80% of our hospitals encounter limited English proficient patients frequently, meaning daily or weekly. But sadly, less than a third of our hospitals have quality improvement efforts underway to improve the quality of their language access programs. What does that mean? In effect, what that means is we have no way of knowing what the quality is of the interpretation that's being delivered in US hospitals, or the quality of translation, because language access is both, right? Only a third of US hospitals have quality improvement efforts that focus on improving the quality of their language access programs. Even worse, if you look at physician clinics around the country, 97% of our physicians treat LEP patients, but barely half of doctors' offices offer any language access services whatsoever, despite the fact that nearly half of US physicians would tell you that language and cultural barriers negatively impacts their ability to provide high quality care. This is very much a legal issue as well. And I won't overly bang the drum on this, but it's really important to understand that if we fail to provide language access services to limited English proficient patients, that's a form of national origin discrimination. If we fail to provide language access services to our deaf and hard of hearing populations, that's a form of disability discrimination under the Americans with Disabilities Act. So there are now 3 federal laws, Title VI of the Civil Rights Act of 1964, the Americans with Disabilities Act, and most recently, Section 1557 of the Affordable Care Act, that guarantee language access to these populations. Secondly, this is very much an informed consent issue. American courts have held that patients' informed consent will be invalid if not obtained by a qualified medical interpreter. Those cases have been on the books for quite some time. And yet I can tell you from our research that many, over a third of American physicians, do not always use qualified interpreters during informed consent discussions. Why is that a problem? Because it's not discretionary, it's mandatory. Finally, this is a medical malpractice issue. And unbeknownst to many healthcare providers, language access violations are civil rights violations, which typically are not covered by medical malpractice insurance. So this is an area where many providers are actually going bare. Final issue I want to talk about, and then I'll wind up, is this: the emerging issue of global medicine. Over the last few years, 1.5 billion travelers cross international borders each year. 80 million foreign travelers came to the United States in 2018, and 42 million of our citizens, US citizens, traveled internationally and then returned home to the US. Globally mobile populations increase chances of pandemics, as we're certainly seeing with COVID-19, because of the increased spread. Yet sadly, only 38% of US medical schools have formal programs in global medicine. In the aftermath of World War II, John Kennedy wrote a book called Why England Slept. I'm convinced that after this COVID-19 pandemic is over, someone's going to write a book about why America slept. And one of the reasons why it slept and why this pandemic became so widespread is the failure of US medical schools to teach global medicine. Lack of global medical training increases chances of misdiagnoses because many diseases of foreign origin share the same symptoms, typically fever or a flu, as common domestic conditions. So one of the things that I've learned, and I do a lot of speaking about unconscious bias, but one of the unconscious biases that medical students learn is they're taught the adage early on in their medical education careers that if it looks like a horse and it gallops like a horse, by God, it's probably a horse. Don't be going out there looking for zebras, right? And that made sense when the world was less globally mobile. Most illnesses are going to be something that's quite common, but that's becoming less and less the case in a globally mobile world, because today our physicians are seeing a lot more zebras. They're seeing many more diseases of foreign origin in the United States: dengue fever, chikungunya, the Zika virus, malaria, strongyloides, schistosomiasis. Let me just give you 2 quick examples of what can happen when doctors fail to have formal medical training in global medicine. So in my home community of the Twin Cities here in Minneapolis and St. Paul, we've seen growing numbers of Hmong patients show up in our hospitals with what appears to be COPD, chronic obstructive pulmonary disease. Do they have COPD? No. What they actually have is an infectious disease, a parasitic disease called strongyloides. If you treat strongyloides with steroids, which is typically how you treat COPD, it only spreads the disease and kills the patient. We've lost 14 Hmong patients in Twin Cities hospitals because our doctors were not able to sufficiently diagnose and treat strongyloides. Why is that a problem? Because strongyloides and schistosomiasis are among the 5 most common infectious diseases brought to the United States by immigrants and foreign travelers. That led researchers at the University of Minnesota to do some international research comparing the ability of US physicians against foreign physicians to diagnose and treat these kinds of illnesses, particularly strongyloides. What they found was that US physicians were woefully unprepared to treat these international diseases of foreign origin. So we've talked about 3 demographic megatrends. We've talked about their implications for the workforce and their implications for patient care. And now I'm going to turn it back over to Katina, and I think we're going to take a short break. Thank you.
Thank you so much, David. And welcome, Dr. Henning Smith. We are going to take, rather than 10 minutes, because I went on too long in the initial session, we're going to take a 5-minute break. It's 1:45 p.m. And if we could return at 1:50, that would be great. Dr. Henning Smith will be ready for you at that time. 5-minute break, everyone, 1:50 p.m. Thank you. Welcome back. And welcome to Dr. Carrie Henning-Smith from Minnesota. Both of our featured speakers happen to be national experts lodged in Minnesota. So we're so glad to have you. Dr. Henning-Smith is an assistant professor at University of Minnesota School of Public Health, where she's taught for 3 years. Since 2018, she has served as deputy director of the University of Minnesota Rural Health Research Center. And she also serves, this woman doesn't stop, as director of graduate studies for the health equity minor in the School of Public Health. She's a national leading researcher on health equity in rural areas, including work on race and ethnicity. She apparently, and I haven't heard it yet, appeared on NPR on Saturday discussing the impacts of COVID-19 in rural areas. So you might want to look that up as well, or we could send you the link later. It gives me great pleasure to welcome Dr. Henning-Smith to our first series event. Thank you.
Thanks, Katina. I'm delighted to be here. Always happy to present alongside another Minnesotan too. And I'll say about NPR, I was on NPR talking about COVID, and it'll be a good day when I don't need to be on NPR talking about COVID. The disparities we're seeing in rural areas are horrifying and have been keeping me up at night. But here I'm going to talk not so much about COVID, but about rural-urban disparities in health and healthcare, broadly speaking. So I will share my screen here. Let's see, are you seeing the slides? I think so. So I'm going to talk about racial and ethnic inequities in health and healthcare among rural residents. And my suspicion is that I am preaching to the choir a little bit, and that I'm following on what you've already heard from Katina and David. But hopefully, if you're not convinced already, this will really drive the point home. So let's see. I want to acknowledge my colleagues at the Rural Health Research Center and also my funder, the Federal Office of Rural Health Policy. We are one of about 7 rural health research centers funded by the federal office across the country, and they all do fantastic work. I'll give you a resource at the end of the slide to check out some of the other rural health research coming out of these centers. So just some background, rural-urban disparities are really well known, well documented. We know rural residents don't get a fair shot compared to urban residents. And as David talked about very articulately, we know that disparities in health and healthcare by race and ethnicity are also really well documented. Rural areas have always been racially and ethnically diverse. I don't think that this point is made often enough or strongly enough. And rural areas are increasingly diverse today. I think David's slide about the global majority really emphasizes that point. Today, across the United States, 1 in 5 rural residents identifies as a person of color or someone who is indigenous. Despite all of this, most of the research on health disparities focuses either on rural-urban differences or on racial and ethnic differences in healthcare. We don't know enough about these within rural differences. And so I'm going to introduce just a few highlights of some of the research that I've done at the Rural Health Research Center to try and illuminate those. First, to emphasize my point about who lives in rural areas and how that's changing, the share of people living in rural areas has changed. It's getting smaller as the years go on. This is looking within counties. There are different ways to measure rural, and depending on how you measure it, this number fluctuates between about 14 to about 20% of the population lives in rural areas, and that's a share that's declining over time. And rural areas are becoming less white, as are urban areas and suburban areas. Rural areas are those over on the right side of your screen. They, in 2000, were 82% white, and as of 2016, they were 79% white. The next census data is going to show us that it's even lower. This is true right in your state of Vermont too. And thanks for Katina for helping me access some of this information. Vermont, as you know, is a more white state than many other states across the country. But even within Vermont and even within rural areas of Vermont, the racial and ethnic makeup is becoming more diverse and less white as time goes on. And we talked a minute ago about COVID. COVID is ravaging rural areas for a variety of reasons, structural reasons. People have less access to healthcare. People have barriers to social distancing. But within that, we're also seeing racial disparities in COVID. And this is true in Vermont too. This is not just looking at rural populations, but in Vermont, your state is 93% white. And yet, the people who are white in Vermont make up a smaller proportion of COVID cases. This is true if you look at COVID death too. We know that racial disparities are longstanding and continue today. I'm going to share some work that I did looking at county level differences in mortality for rural residents by racial and ethnic composition of the county. And I'm showing here a couple of publications that I'll highlight. I believe that Katina will be able to share these resources with you, and feel free to email me if you'd like copies of anything too. So the question is, among rural counties, how does mortality or premature death vary by the composition of the county, by how white or not white the county is? For this study, I used the 2017 County Health Rankings. You're probably familiar with those. If not, it's a wonderful resource out of the University of Wisconsin. And I compared counties by their majority racial or ethnic group. This is a very blunt way to do this, but a way to indicate that there are some disparities that we need to be very concerned about. This is a map of all of the counties across the country. Those that are gray are metropolitan or urban counties, and I didn't include those in the study. Everything else that's colored here is a rural county. I think it's worth pointing out that rural counties make up the vast majority of the country. Something like 90% of all land mass in the country is rural. And so it might be a small share of the population, but it's certainly a big share of our country. And you can see here the majority racial or ethnic group in each rural county. The light blue or aqua is majority white counties. And this is certainly the majority of all counties. It's about 88% of all rural counties. But importantly, it's not all rural counties. Those that are red in the southeast part of the country are majority Black rural counties. Those that are kind of mustard colored are majority Hispanic rural counties. You see those along the Rio Grande in the Southwest, and a smattering in northern counties where we see a significant amount of agricultural production. Those that are dark blue are majority Indigenous or American Indian. And those that are green don't have a majority group. These are really heterogeneous populations where we're seeing a mix of different groups. That green group is growing over time. And I suspect that if we were to go back and overlay the new 2020 census data when it's available, we'll see more colors on this map. We'll see fewer of those majority white counties. When I'm showing this map, I always like to make the point that these are not randomly distributed. And you can see history by looking at this map. You can see the lasting implications of slavery and where people were forcibly located to by looking at this map. You can also see where the US border might have crossed over into what used to be Mexican territory on this map. These are not coincidental. This is not random. There are structural and historical reasons why this map looks the way that it does. And why does this matter? It matters because there are differences in the resources available to people based on their county level racial or ethnic makeup. That I'm just showing you a few here to emphasize that point. It's worth noting that the median household income in rural counties that are majority Black is $15,000 less than the median household income of rural counties that are majority white. We hear a lot about the issues of poverty in rural areas and poverty among white individuals in rural areas. And this is a real issue. I don't want to trivialize it, but I think that this chart, this table drives home the point that that's not the whole story. And there are other people who face even bigger inequities. Similarly, the unemployment rate is nearly double for those counties that are majority Black or majority Native compared to those rural counties that are majority white. And the limited access to healthy foods, this is kind of a wonky measure, but it measures how far away you are from a grocery store where you can access healthy foods. This is triple, this limited access to healthy foods is triple in those rural counties that are majority Indigenous compared to those counties that are majority white. Again, this is not random. This is structural racism at work. These are inequities at work. And why does this matter? It matters because it shows up in our health outcomes. It shows up in our mortality statistics. I'm showing you here a chart that looks at differences in premature death by type of county. These are, again, just rural counties, but looking within those rural counties and what their majority racial or ethnic group is, what is the rate of premature death? And premature death, for those of you who are not epidemiologists, is kind of a goofy measure, but it's one that we use a lot in public health to compare health across populations. And it's asking how many years of potential life lost are there for someone who died before the age of 75? We assume that most people will live to about 75. And if someone dies sooner, then those years go into this measure. The higher the bar on this chart, the higher premature mortality we see in a population. Two important takeaway points from this. Those lighter colored bars are unadjusted. We're just looking at the raw premature death rates. I'm not accounting for any differences in income or employment or access to healthy foods or any other measures like that. When I look at the unadjusted measures, those rural counties that are majority Black and majority Native have significantly higher rates of premature death compared with those rural counties that are majority white. After I account for socioeconomic status and healthy food and all of those other things that I talked about before, that difference mostly goes away for those rural counties that are majority Black. This tells us that interventions in economic activity in the counties, in access to food, and some of those structural barriers would really make a difference in reducing those disparities. But the difference doesn't entirely go away for those counties that are majority Native, majority Indigenous. And this tells us that there's even more happening. We have even greater inequities in those counties that need to be addressed. And I want to share just a few snippets of disparities in access to care among rural residents by race and ethnicity. I think David talked about these really well and talked a lot more about language barriers, linguistic barriers than I'm going to talk about. But I want to leave you with just a few statistics to show you that this is an issue. It's not just a matter of health, but it's a matter of health care. And this is research that my team and I did using the National Health Interviews Survey and looking again just at rural residents. This is a policy brief. It's freely available on our website, and I believe that you'll get access to this after the presentation today too. Looking at disparities in preventive care for vaccinations. I know vaccinations are on my mind right now. I suppose that they are on a lot of your minds too. I hope that we don't see disparities like this in the COVID vaccination, but we do see disparities in other common vaccinations. For annual flu shot, this is asking people if they got a flu shot in the past 12 months and pneumonia shot ever. Have you ever had a pneumonia shot? We see really troubling disparities for Hispanic rural residents compared to white rural residents. We don't see very dramatic inequities for any other group, but we really do see barriers in access to care for Hispanic residents. And I suspect some of this may have to do with some of the issues around immigration and linguistically appropriate care that David mentioned, but I think there are other things at play here too. We see similar outcomes when we look at access to screenings, whether people have had any number of these very common cancer screenings. And when these questions are asked in the National Health Interview Survey, they're only asked of the people who would qualify for the screening under the current guidelines. So would you qualify for having a breast exam? Are you in the right gender and age group for that? Same for colorectal exam screening, mammograms, pap smears, and PSA tests. And here, once again, we find that the disparities are most striking for rural Hispanic residents. There's clearly an inequity here. They are much less likely to have gotten almost all of these common cancer screenings. This matters a lot when we think about timing of diagnosis, when we think about prognosis once someone is diagnosed with cancer, and about eventual potential mortality and outcomes from the disease. I want to leave you with just a few key takeaway points here. I don't think it took a lot of convincing, but I'm showing you that there are disparities among rural counties and rural residents by race and ethnicity, and non-Hispanic, Black, Hispanic, and Indigenous rural residents tend to fare the worst, depending on which measure we're looking at. Some, but not all of these disparities are explained away or mediated by differences in socioeconomic status. This carries several implications. First, it's really important to invest in rural communities financially via employment opportunities that might improve access to care and access to economic resources. And any such investment needs to take into account the inequities that are already baked into the system and ensure that the people who have suffered the most, who have the least fair access to economic opportunity and to health and healthcare right now, are put at the front of the line for any investments. But investing in rural communities and in economic opportunity is not enough. We need to also address the lasting impacts of structural racism in our communities, including in rural communities, in order to improve the health of all rural residents and communities. So I'm a researcher. I always like to leave with a point about research, what research should do. And I believe that research should look beyond disparities by rural and urban location and by race and ethnicity. We need to understand the intersection of race and racism and geography to understand how those are working together. I think I made that point already. And with rural populations becoming increasingly diverse, this is only going to become more urgent. I won't say more important. I think it's always been important, but we're going to see more and more people impacted. There are several things that we can do to implement change. This requires investment at the state and federal level in healthcare, but economic opportunity, transportation, which I didn't talk about much, but it's a persistent issue in rural communities, technology and connectivity. This matters a lot when we're thinking about how we're living our lives with COVID these days. Do people have an equitable opportunity to work from home, to socially distance, to learn and study from home? They don't. That's the short answer there. And we need to address the digital divide, especially as it's divided by race and ethnicity. We also need to make sure that voices from the communities most impacted, so from BIPOC rural residents, Black, Indigenous, and people of color rural residents, are at the table for any decision-making process. And again, this is only becoming more urgent. I want to thank you for your time today. There's my contact information. I'm happy to have you follow up with me if you have any questions. And as promised, I want to leave you with this final slide and give a plug for the Rural Health Research Gateway. This is a federally funded website that houses and shares and disseminates all of the research of all of the different federally funded rural health research centers. So if you're interested in an issue in rural health, this is a good place to start. I nearly guarantee that if there's a topic you're interested in, it's been covered by a researcher, and the research is included on this site. But I encourage you to challenge me on that and check it out for yourselves. I'll stop sharing my screen. And again, I really appreciate the time today. Oh, Katina, I think
there we go. Okay.
It's just a daily thing.
It's a daily thing. I tried not to, but thank you so much for that presentation. I think it's a key issue in every state that has rural residents, especially a state as rural as Vermont is. So thank you for this research and for the work you're doing. So for the next about 5 to 7 minutes, I've had to shorten a few things. We're going to offer a reflection exercise. Dr. Henning Smith and David Hunt are going to stay with us, with the presenters responding to your questions, or to your questions, to your reflections. And we're going to ask you to select one of these questions and enter your thoughts in the chat. What steps, you can choose any of the three. What steps has your organization taken to cultivate or promote health equity within your practice? What are your organization's current strengths and or challenges in providing care to underserved populations in your area? And how do you know that? And third, does your agency or practice collect patient race, ethnicity, and language data, which we now call in the public health world real data? If so, how is it used? And in particular, do you tie that data to patient outcomes or other measures? So feel free to please pick one and answer, select one, and then enter your ideas in the chat. And I will be reviewing those and sharing them with our two key presenters. So I see that one of our participants said that they're starting to look at quality measures broken out by race and ethnicity, and language is on the to-do list. And they measure on behalf of FQHCs. So that's a positive beginning for FQHCs. David or Carrie, would you like to respond to that?
So I'll take a quick response, perhaps. One of the things we know is that a couple of years ago, the American Hospital Association created a program called #123 for Equity. About 180 American hospitals, that's about a third of American hospitals, are now participants in that program to collect patient race, ethnicity, and language data. That's an encouraging step. Unfortunately, however, the vast majority of hospitals that collect real data don't do it efficiently or effectively. And we know that because we've actually audited a lot of that data. And in many of those hospitals, they have more patients who show up as race unknown or patient refused or anything else than patients who are actually racially identified. So that's an initial problem. But an even bigger problem is once you have collected that data rigorously and well, less than half of American hospitals currently tie that data, real data, to patient outcomes. So we're never going to get a handle on racial and ethnic disparities in American healthcare until and unless we do both of those things: collect patient race, ethnicity, and language data, and tie it to patient outcomes.
Great, thank you so much. We have a comment that Brattleboro Memorial Hospital is formalizing a council on racial equity to look at how to change our culture and policy to reinforce health equity. That's very exciting. I wanted to comment, let's see. One of the rural networks collects race and ethnicity data as a requirement of HRSA funding and factors that into 3 quality measures, but not with others. So it'd be good to expand that analysis. That's really excellent. That's hypertension, diabetes, and prenatal, David, are the 3 quality measures. Would you or Carrie like to comment on that? That's an FQHC, by the way.
I'll comment to say these are giving me so much hope. I love hearing this. This is wonderful. To back up David's point, just to emphasize the importance of collecting data. We don't know what we don't know, and we often, it's tempting to just hide in our blind spots. But I think collecting this data and then really looking at it and doing some soul searching about how to act on it is so important. And I'm really heartened by the organization that is putting together the Council on Racial Equity. I'd love to learn more. I'm curious who has a voice on that council and how will they be able to enact change. I think sometimes we form councils, but they're not given real power to enact decisions. I trust that this one will be, and I would love to learn more about it.
Great, we can share that with you, Carrie, as I learn more about it as well.
Please do.
Absolutely. You know, I do want to say it's okay that we don't know the answers to these questions. A couple of people have noted that they feel they should know and don't know. This is a journey for all of us, and I just want to emphasize that these are questions that I hope you go back with to your colleagues and your practices, and it's fine not to know right now. Okay. Does CMS require this? I think you're talking, yeah, the data. VNNH attempts to collect some of the data, but I don't know what it's being used for. Do you know if CMS requires this, David or Carrie?
That's a great question. I think it's being increasingly required for Medicare patients, but I couldn't swear to that.
Okay.
Carrie, do you know?
No, that would be my response too. But I think it's telling that we don't know the answer to that, and also that I couldn't tell you exactly what they use it for. I know CMS has been grappling with whether to do more adjustment in how they measure quality, and race has been part of that conversation, but I'm not sure where exactly they are in that conversation at this point. They've had some turnover in their office there too.
Okay. I'm going to pass along, we're at 2:20 right now. I'm going to pass along these comments to our guest speakers if they choose to respond later, or I can respond with you after they've looked at them. But we are going to need to move on as we are planning to end in 10 minutes. So thank you both for those responses. And again, we will do our best to respond to the other comments and questions.
Thank you.
Thank you so much.
Good to be with you.
Thank you. Thank you so much. David is staying on. And I am going to spend about 3 or 4 minutes introducing the path to culturally and linguistically responsive practices. And then David is going to join in a brief conversation before we end our session. Next slide, please. So there are a number of key components to cross-cultural care that we have already discussed today. And I think it's easy and fair to say that culture plays a huge role in how people define health, their own health, how they interact with the healthcare system, and how they interact with their providers. Next slide, please. So as our country becomes more diverse, of course, providing culturally responsive and appropriate care is important. What is cross-cultural care anyway? I think David and Carrie have addressed this question, but what's important for us to know is that it is an extension of patient-centered care. We all know what patient-centered care is, and it includes paying particular attention to those social and cultural factors in managing medical encounters with patients who happen to have different social and cultural backgrounds. Dr. Betancourt, that David referred to and I did previously, discusses the patient-based framework that allows the clinician to learn from the individual patient how those social and cultural factors influence his or her health values, beliefs, behaviors, and offers strategies for the provider to negotiate for the best health outcome possible. Next slide, please. So what is culturally responsive care? I have distilled it to 3 main points. It's culturally specific, it's honoring, and it's appropriate. What I mean by culturally specific, it is responsive to the diverse beliefs and values related to health and well-being in a person's particular culture. And by the way, notice we say culturally responsive care, which places an emphasis on the capacity of providers and health organizations to respond. Secondly, it's honoring. It's grounded in a cultural view of medical care in which multiple expressions of diversity are recognized and regarded as assets, not liabilities. Practicing mutual respect for experiences and qualities that are different from one's own. And these are assets. These are individuals who possess vibrant realities, and they have a rich reservoir of knowledge, not only about their own health conditions, but also about their families and their communities. And making sure that care is appropriate, to be mindful of health literacy of the patient, and delivering services in preferred languages, as David was saying, through qualified interpreters and quality translation services, which include also addressing appropriate dialects of individuals, not just languages. So at this point, we could get into more of a discussion on cultural effectiveness, but I wanted to conclude this part by saying, when a clinician interacts with the patient, 3 cultures meet: the patient's culture, the clinician's culture, and the culture of medicine. And all 3 cultures influence the outcome of an encounter, and whether it's a positive or negative outcome. Next slide, please. Keep going. Next slide, please. Next slide, please. Next slide, please. And I wanted to mention here that everyone we know has a culture, and those are patients and providers alike. That our culture, American culture, is different from many patient cultures, and resistance to cultural and racial differences is part of being human. Reactions are automatic and often subconscious and can influence strongly that provider-patient relationship. A provider's culture is influenced by his or her own personal values and beliefs, and also American medical culture. And it requires us to do the kind of self-reflection, self-analysis, and positive movement to address those biases and understand our system in a different way. Okay, I would like to now go to the questions. I would like to go to the final questions with David. And David, I'm going to ask you one or two questions before we end up, and we only have time for probably one. David, do you think that there is, have you found that empirical evidence shows that efforts to educate healthcare clinicians in cross-cultural care, such as this educational series, improves knowledge as well as attitudes and skills?
Yes, and I think that there's a lot of good research on exactly that point. Dr. Joe Betancourt at Harvard, the Disparity Solutions Center has done a lot of excellent research on exactly that point. And if you're looking for answers or articles, look up Dr. Joe Betancourt's work, and I think you'll find the evidence, supporting evidence there.
Terrific, thank you. And if you could comment, if you have, well, actually, we're going to need to go, but if you wanted to make a comment briefly about how has the field of cultural competence evolved to clinical competence in a globally mobile world? If you're able to comment briefly on that.
Sure, I think that tracks back, Katina, to what I was talking about earlier, that, you know, I attended the first national conference on cultural competence in healthcare way back in New York City back in 1999. The entire focus was on the United States and predominantly on sort of cultural and linguistic competence. And what was missing from that was the element of global medicine, which I introduced in my talk. And we'll be talking a lot more about that during our next session on January the 28th.
Yes, thank you, David. Thank you. So we're going to wrap up now, and I want to share with you what we have put together and you'll be receiving in the next couple of days. Thank you so much, David.
My pleasure.
We hope you are inspired now to continue this work with us on your own and with your colleagues in your own practices, communities, and others. We hope that you will register for the next sessions, the upcoming one on January 28th that David just mentioned. We have also developed suggestions for next learnings, a series of questions you can explore with your colleagues as you are guided to enhance your capacity to provide equity-oriented services. We will send these to you via email in the next day or so, as well as a list of resources we have compiled based on today's presentations. And both presenters today have sent me articles and materials that you will be interested in pursuing. Please complete the brief evaluation form at the end of the session. The link to the form, the registration form for participants seeking CE, will be uploaded in the chat. If you miss either one of these resources, we will send them to you by email immediately following the presentation. Some of you who know me very well know my love for poetry, for excellent poetry. And I remembered last night the poem by the Spanish poet Antonio Machado. And he wrote, "Wander, there is no road. The road is made by walking. By walking, one makes the road. And upon glancing behind, one sees the path that will never be trod again." That's a path of inequity and inequality that we do not want to keep traveling down. And we hope this session has inspired you to be a part of the solutions. Thank you for joining us and becoming a part of this learning community for health equity in Vermont. Bye-bye.
Thanks, everybody.
Thank you.